Well, that was fantastic. And I think I learned so much from the Premium IOL section. But the first things first, can all the panels, there's a lot of questions in that Q&A box. I really want all the panels, if they can actually go ahead and start answering some of those questions while they're at it. And meanwhile, I'll continue with the next session. And before we move to the next session, I wanted to tell everybody, we asked a question to Priya Narang. And the question was, what technology are you looking forward to? And this is what she had to say.
Presenting here is the Advanced Vision Analyzer. It comprises of a head-mounted device similar to a virtual reality headset, a patient response pattern, which is a handheld device, and an Android tablet that serves as a controller to perform, record, and analyze the test program. The head-mounted device is lightweight and it allows a high degree of flexibility in patient position. The HMD is battery-powered, has an adjustable headband, and records the patient's response after the presentation of the stimulus. During the test, the system obviates the need to occlude the fellow eye. The patient response pattern is connected to the HMD through a wire, and for a given stimulus to be recorded as seen, the patient presses the button. The computing system then determines the test results with the recorded information. The test control device is a tablet that is connected wirelessly to the HMD, to the patient response pattern, and to the cloud server. The device is portable, does not need a dark room to perform the test, and can also be performed in supine position. To set up a test, the administrator initially logs in and pairs it with the headset, followed by input of details. The tablet has HMD details, settings, new tests, and reports. AVA offers white-on-white perimetry with a stimulus intensity that ranges from 0 to 40 decibels, and the test is performed with Goldman 3 stimulus size. The test details can be set by choosing the eye that needs to be tested, followed by the test pattern, that is either a 24-2 or a 30-2 program, or a test strategy that can be either a screening, full threshold, analyzer zest, or analyzer fast. Other details that are fed into the system include personal details such as patient's name, age, sex, that help to retrieve the stored data, which is stored on the backend server. The clinical data on AVA is encrypted and is therefore secure. The eye tracking system tracks the pupil movement while the test is being conducted. Hence, it helps to check for fixation losses. The interpupillary distance can be adjusted. Refractive errors can be corrected. The printed test report consists of patient information, reliability indices that comprises of fixation loss, false positive and false negative, absolute threshold values and grayscale pattern, gradient plot based on defect significance, and global indices that are compared with a normative database built specifically for AVA. These are the various kind of visual field defects detected in grayscale pattern.
Well, that's what Priya had to say about the technology that she's most looking forward to. We have the special offer from the ASCRS themselves for all the attendees of the WWCRS. This basically means the 400 hours of educational content that is available on the ASCRS virtual platform is now on a discounted rate for the World WCRS participants only. We would like and urge everybody over here to actually go ahead and sign up for this, because it's one click away for 400 hours of educational content that is galore that you would get in an actual ASCRS live meeting. From the videos to the live debates, as well as posters and everything that an actual live ASCRS live meeting has. Having said that, we should now move ahead with the polling question. And let's do the polling question. Can we have the polling question on, please? A small pupil, to me, should be managed mostly manually as much as possible, using pharmacological agent, Canabrava ring, iris hooks, Malyugin ring, the B-HEX ring, or the APX. And we have 15 seconds to answer this, guys. Get going, get those fingers moving. And can we stop the timer, please? Can we also see the results? Iris hooks is the winner here. Now, we don't have iris hooks in this next panel, but let's see if we can move that needle to any of the other rings and other agents available. Can we close the share polling, please? Can we also introduce these great set of moderators, panelists, and speakers? Can we have the video?
Small pupil session. The coordinators. Boris Malyugin and Bruno. Guest panelist. Gaurav, Luthra, India. Featuring speakers. Boris Malyugin, Russia. Manuel Nicoli, Argentina. Suven Bhattacharjee, India. And Ehud Assia, Israel. Organizers. Sergio Canabrava, Brazil, and Ashwin Agarwal, India.
Dear colleagues, it's my pleasure to be with you today and to thank my co-moderator Bruno and Gaurav for joining me for that session, and welcome to the small pupil session. I want to also thank Sergio and Ashwin for the great, fantastic event they organized and we are witnessing today. So let me start with my talk, and I will try to squeeze it into 600 seconds because the topic is quite broad. Intraoperative floppy iris syndrome. We know this is the syndrome consisting of three typical symptoms: floppy iris that
Can we move along with another presentation?
Okay. Do you hear me?
Hi.
I think we have Boris back. Yeah.
Okay. So it was probably internet connection. So at what point did it stop? I don't know, but I just want to come back one slide back and to credit David Cheng and John Campbell for introducing to our surgical community of this syndrome. And we know that there is a long list of drugs which is correlated with that syndrome. The pathomechanism is the thinning. How is that now?
Yeah, you're back.
Okay, I can move on. So as shown here, this is a OCT study showing the thickness of the muscles, and this is the difference with dilator muscles in the healthy subject as opposed to the patient taking tamsulosin. So this is the also again treated patient having much thinner dilator muscles as opposed to control subject. So there is one more mechanism involved in that, which is related to the iris vascular dysfunction resulting in poor pupil dilation. So there are certain risk factors: gender, age, and systemic hypertension. IFIS risk factors also including the pupil, which is smaller than 7 millimeters. There is also significant relationship between IFIS and axial length. The shorter the eye, the worse the situation. Also, we do have different corneal sizes. So there is not only the size of the pupil, but the ratio in between the pupil size and the limbal diameter, which is very important to keep in mind. IFIS incidence varies significantly from 1.1 to 12.6%, and this is most recent studies showing in a substantial amount of patients from 947 to more than 4,900. So we see that the overall incidence is from 9 to 12.6%, which is quite significant. So IFIS can be graded as mild, moderate or severe based on the number of symptoms that we can see. So the development of IFIS is quite quick because it has been reported even after 48 hours after tamsulosin intake. So that's why there is no reason to stop the medication before cataract surgery. IFIS is associated with increased ocular inflammation, posterior capsular rupture, anterior capsular tears, vitreous loss, iris trauma, and cystoid macular edema. And the rates of posterior capsular ruptures range from 7 to 12%, which is much higher than we can see in the usual setup. Iris changes, these are the early slides, and we can see might be quite substantial with the loss of substantial amount of iris tissue. So what medications we can use? Atropine is quite useful as a preoperative medication, as well as non-steroidal anti-inflammatory drugs. They help us to reduce the issues with pupil dilation. Also, we can again judge by the pupil size, and the patients having pupil size less than 7.5 millimeter having fourfold increased risk of having problems intraoperatively. Intracameral mydriatic agent is a way to go, as shown here. By injecting mydriatic agent, you can actually not only dilate the pupil, but strengthen and improve the biomechanical properties of the iris. Surgical technique, we need to use elongated corneal incisions. We need not to be very forceful with our hydrodissection, lower fluidic parameters, and trying to keep the irrigation flow above the iris plane. And this is another advice from Steve Arshinov, who is using soft shell breach technique, where dispersive viscoelastic is coating the cornea. Viscoadaptive is located in the center of the anterior chamber, and above the capsular plane there is a VSS field space, which helps to manipulate within that area. But you have to keep in mind that you need to keep the fluidic parameters very low, flow less than 20 ml minute, and aspiration 200 millimeter hydrergia. Clinical results are quite variable. We know that IFIS group provide us longer surgical time rather than in patients that do not have any problems. What about the devices that we can use? Iris hooks in a diamond configuration, when one of the hooks is located behind below the main incisions, is a very helpful combination. Also, the Malyugin ring, which is reported in 2008, was the first report was by David Chang, who was using that in 30 consecutive IFIS cases. So the use is quite straightforward. You inject here. You see that the pupil starts off quite big, but as soon as viscoelastic was leaving the anterior chamber through the paracentesis, as shown here, we see that the pupil starts to constrict, the iris starts to incarcerate into the side port incision, and the surgery becoming more and more challenging. So this is the time when you may consider stop and then think what device you should be using here. And in that case, I was planning to use the pupil expansion ring, and shown here, you see when I injected viscoelastic, again pupil become quite big and quite wide. So it was quite typical for these eyes. That's why I like to use bigger ring, which is 7 millimeter rather than smaller one. Iris retaining points, which are 8, shown here, help you to keep the iris in place. And this is the modeling of the floppy iris syndrome. As you can see here, the billowing and buckling of the iris in a small pupil situation is quite intensive, with a very small buckling pressure. However, when you keep the iris in 8 points, as it happens with the pupil expansion ring, There is a little bit of buckling in between these pupil fixation points. However, the whole situation is quite stable. Pupil expansion rings show to be very useful in most of the IFIS cases. They require less operating time, do not require extra incision, provide stable pupil during the surgery, and minimizing postoperative pupil deformity. And it also decreases the surgical time, both in consultants and trainers alike, as compared to the iris hooks. So that takes on average 10 minutes longer. So the surgery is much longer with iris hooks. So there are several other devices should be mentioned. B-HEX will be discussed later on during the surgery, but there are also other devices that are available on the market. So to summarize my talk, there are several critical aspects, including stratification of risk, preoperative prophylaxis, intraoperative treatment, surgical technique, and intraoperative management. But you have to keep all these take-home messages in mind when dealing with that type of patient. And I thank you very much for your kind attention. Bruno, we can hear you. Please switch on the microphone.
I'm sorry. Congratulations on your excellent talk. Thank you for sharing such knowledge, and thank you for developing such an elegant instrument that help us all around the world with small pupils. I mean, it was amazing. It's before Malyugin ring and after Malyugin ring our approach for small pupils. I think it's better to go along with the next speaker, and then we have some time to discuss later.
Okay, thank you for the invitation. I'm very honored to be here. Thank you, Dr. Ashwin Agarwal, and thank you, Sergio, for the invitation. I'm Manuel Nicoli from Buenos Aires, Argentina. I'm going to talk about iris expansion rings in FLACS and shallow anterior chamber. I'm going to talk about the Canabrava's ring. It's a ring of PMAA with an opening of 60 degrees. It was built in a 3D printer. This has an intervallar diameter of 6.3 millimeters, a vertical length of 0.4, and two small hooks at each end, and 7 eyelets with an upper slot and a lower slot. Each eyelet has a 0.28 millimeters for manipulation for a Sinski hook. This is for insertion and removal of the eye with minimal incisions. As we said, the height is 0.4 millimeters. You have here the big eyelets and the smaller eyelets. The big eyelets go over the pupil edge, and the smaller eyelet goes under this pupil edge. Other rings has more height between 0.7 and 0.9. They're not aligned, they're alternate eyelets, so that gives you a wavy configuration for the iris to hook on. We're gonna see here a video of how we introduce. We use a McPherson forceps or similar. Then we use the Sinski hook to put the ring. First goes the central eyelet, and then we move to the lateral eyelets to centrate the ring. And as we do this, there's some tension in the iris, but it's going too perfect. And then we put the hooks to finally set the ring. We're gonna see some different surgical situations using this device as to see the efficacy, the stability, and the security of the ring. Here we're seeing a very hard cataract surgery with a lens pressure into the ring, and you see no movement on the ring. Then we're gonna see a posterior capsular rupture in an eye with a vitrectomy eyes, and some sectorial iridectomies and colobomas you can use, and posterior synechia. You can use them in those cases. And here we see an Argentinian flag case with a ring on, and see the stability of the the ring at the end of the case. This is how we disengage the ring, and we move forward to the anterior chamber, and then we pull it out with the McPherson. I think the two advantages of this kind of ring we can set is for the shallow anterior chamber. As we said before, it's 0.4 millimeters of height. Other rings have 0.7 and between 0.7 and 0.9. So we reduce the endothelial contact throughout the procedure. Here we see a case of a very small pupil. As you can see, we are introducing the ring with viscoelastic. The capsule was stained with blue trypan, and then we do the exact procedure to put the ring on. As you can see, we got a very good pupil to do our case. The other thing we think it's very useful is for the FLACS, for the femtolaser assisted cataract surgery. Here we have the ring put in a catholics procedure. As we can see the red arrows, there's the ring. This is a video from Bernardo Tombach from Brazil with a case of Canabrava ring. The utility of this, if we use an incision of 1.4, we put the viscoelastic, then we wash it out with VSS. We irrigate the incision. We don't use a suture. We check the pressure of the eye, and we go to the femto. These are 4.7 Rexis with a catalyx machine. You see here perfect, all the ring in position, and the case began as usual, and you can see the perfect Rexis and the final of the surgery. And here's the publication in 2018 of Sergio Canabrava with 30 cases. Actually, nowadays, the Brazil is commercially available. In Europe, it's available, but with the pandemic, it's already stopped. I began using this ring last year. I was the first surgeon in Argentina to use it, and I think it's an excellent option in our management of small pupil. And I want to thank you all for your attention.
Thank you very much, Dr. Nicole. I think it's a nice talk and a nice presentation, and also I think it's worth to discuss a little bit about the femto and pupil expansion rings. So, do you? My first question: do you leave viscoelastic in the anterior chamber when you do that, or you prefer to remove it?
With
Switch
the
on
femto?
the microphone. Okay. Yeah.
With the femto, I forgot to tell you, but I don't have any experience with the femto in using the ring with femto. So I use it in normal cases, not with femto yet.
Okay, because.
But I talked to but I talked to Sergio and Dr. Bach, and they try to take all the viscoelastic off the eye and put some BSS and then do the femto.
Okay, because I do have some experience with different ring, but also with femto. So my usual technique, I leave viscoelastic. I use dispersive viscoelastic, and I leave it in the anterior chamber. And also, I like to place the suture. After implanting the ring, I like to place one suture, because even if I'm using 2.0 millimeter incision, I still, with viscoelastic in the chamber, I still can see that after suction applies, there is a viscoelastic that is going out. So I think it's safe to mention that whatever device you use, but do consider placing the suture to make your incision watertight when you do that before femtosecond laser application.
I think, yeah, I think that's a good tip, because we use a 1.4 millimeters to insert the ring. they don't put a suture on it. But it's a very good point you're saying about the, even though there's a suture there, some viscoelastic is going out.
Yeah, that's right. And also, the other thing is sometimes when you place your incision a little bit too limbal, so then there is a little bit of issue with the laser because the bleeding from the limbal vessels can go and obscure the view. So that is also have to keep in mind that you need to be quite corneal and clear corneal, really not to touch the vessels to avoid bleeding, because otherwise it may be quite challenging to do that. But otherwise, excellent. Congratulations with that great experience and great stuff. We do. How about my co-moderators? Bruno, do you have anything to add, or Gaurav?
Wonderful. We have some questions, a lot of questions about using the NSA drops, even with those rings. I think they are useful for controlling inflammation and pain during and after the surgery, and maybe preventing macular edema. Don't you agree, Dr. Luthra and Dr. Malyugin?
Frankly, I don't enjoy. I do a lot of femto-assisted surgeries, and I don't enjoy putting any of these devices for the small pupils. I have done a couple of cases using this new, as Boris showed, with the phenylephrine drops. So we've used phenocaine, which became available to us in India some time back. You can put it through a very micro incision, except that it may not last that long because we can have a constriction. So frankly, I think I would love to try, and I think B-HEX also goes in from a much smaller incision as well. But
yes,
right. So anyway, so that's my thought. Yeah.
As for my experience, there were quite a number of publications showing that non-steroidals are quite helpful in controlling inflammation, and especially they are very useful in femtosecond laser-assisted cataract surgery, and we always use them in that cases. And there were some publications about intraoperative floppy iris syndrome. I mentioned them in my presentation that by using non-steroidal, you can actually decrease the need for any pupil expansion device because the pupil is maintained much better. There are also pharmacology to be mentioned apart from the intracameral phenylephrine or epinephrine. There is another medication which is called Amidria, which is injected into the bottle with BSS, and by continuous irrigation into the anterior chamber, the concentration of the drug is maintained throughout the procedure. So that's why it's quite a good idea to maybe to use that in these cases. Although I'm not aware about any publications related to Amidria use in complicated small pupil cases, but in regular cases, it showed to be effective.
Wonderful.
Okay.
I think it's better to
Bruno?
move to Dr.
Okay.
Next panelist, next talk.
Yeah. So thank you. So it's going. I'm Suven Bhattacharjee. I'm pupil. Yeah. So Dr. Deepak and Dr. Nito for the wonderful videos. The B-HEX is easy, safe, and very affordable. The 75-micron profile is 1/10 the thickness of other devices. Hexagon with notches and flanges. The housing presents the preloaded device at the incision, and the B-HEX 23-gauge forceps advances it through the incision. As alternate flanges are tucked under the iris, the pupil expands. The iris bends at the notches, while the B-HEX remains in a single plane. Notches are disengaged and the device is removed through the main incision. In fact, the B-HEX can exit through a 1 mm side port incision, which no other device can. So, how do we choose our pupil expander? Chang and Campbell published that unlike non-elastic pupils, the IFIS pupil immediately snaps back when stressed. Small pupils, two types, elastic, non-elastic. The elastic pupil can be stretched like a rubber band and any pupil expander would work. Non-elastic one is like a string and can only be torn or broken with a strong, bulkier expander. The choice depends on how you wish to tear the rigid pupil. With two Kuglen hooks, the hair-thin B-HEX allows a lot of space in the AC for instruments. To tear with the pupil expander, it has to be bulky and that would obstruct instruments. The rigidity of the pupil should be checked as soon as we make the paracentesis. As the AC is inflated with BSS, the elastic pupil expands. On the other hand, a rigid pupil does not. The pupil hardly enlarges when BSS is injected. Once the fibrotic band is torn by a bimanual stretch, the pupil now expands and it is easy to use any pupil expander. This is a very simple test to differentiate between a rigid and elastic pupil. We are all skilled enough to perform phaco with the assured 5.5 mm pupil that the B-HEX provides. Publications have endorsed its usefulness in difficult cataract and vitreoretinal surgery. This is an elastic pupil. As alternate flanges are tucked, the pupil expands to 5.5 mm for easy phacoemulsification and IOL implantation. The flanges are untucked and the B-HEX literally walks out of the main incision. And here, the B-HEX is removed easily through a 1 mm side port incision, which no other pupil expander can do and is very useful in tight situations. A rigid pupil and a hard cataract. A bimanual stretch makes it easier to tuck the flanges of the B-HEX. As we can see, the 5.5 mm pupil is more than adequate to emulsify even this hard cataract. And once again, removal is so easy. This is a rigid pupil with a fibrotic membrane. Stretching was not attempted and only the fibrotic membrane was removed. When the pupil still remains rigid, bimanual tucking of the flanges using the forceps and the iris hook or Kuglen hook helps engage the B-HEX with ease. And we have such good visibility for surgery. Despite being rigid and fibrotic, we have a nice round pupil. This is an extremely shallow anterior chamber, and we can see how the 75 micron thin B-HEX can easily be tucked under the pupil margin. Despite the shallow chamber, every step is so controlled and safe, and it allows so much space for the phaco probe and other instruments. The B-HEX never comes in the way of IOL implantation. Here, the pupil becomes small as phaco is commenced. A little viscoelastic lifts off the iris from the capsulorhexis. The uniplanar design and open notches ensure that the capsulorhexis is not engaged as the flanges are tucked. As the flanges are tucked and advanced, there is instant confirmation. And now we are back to our comfort zone. If you are looking for an easy device that allows a lot of space in the anterior chamber, the B-HEX is your go-to pupil expander. If you're looking to tear a fibrotic pupil, you will need a bulky Malyugin or APX. This could be easily done with Kuglen hooks. The choice is yours. Thank you. Yep. Thank you.
Okay. Thank you very much, Suven.
Thanks, Boris.
Thank you very much, Suven, and thank you for the nice talk. And let's listen to the next speaker, Dr. Ehud Assia from Israel.
Yes, good evening from Tel Aviv, and thank you for the invitation to participate in this interesting session. And I would like to share with you our clinical experience with the APX. I would like to first acknowledge that I do have interest in this device. And this is the APX, which is a different pupil expander. It's different from the other either hooks or rings. And the principle of this device is the same that one would intuitively do when he wants to open up a rubber band using 2 hands and 4 fingers. This is what we would do, creating such an X motion. So we apply the same principle into the patient's eye. And these are the 2 devices that we use, the 2 APXs. This is the APX, it's a plastic device. It has a nitinol spring here and a blunt tips on both sides. And it is used using 2 designated forceps so that the nurse can actually load them for the surgeon before he's going to open the pupil. This is how it works. We make 2 19-gauge incisions on the opposite sides and then insert the device inside the eye and slowly open up when the tips are located behind the pupil. So this is one technique. We are going from the inside out, from the center of the lens to the periphery, open up, release the device, and this is it. And note, there is no other instrument inside the eye. All the manipulations are done from the outside. We also place them a little bit skewed so that it creates kind of a trapezoidal shape opening so that the wider base is facing the surgeon, so there is more space for the instruments. Pulling it out simply by using the same designated forceps, close and pull out, and the pupil regains its normal shape. And this is the other technique, going from the outside in. We can actually open up the whole thing, even release it, put some more OVD between the capsule and the iris, and then going from over the iris to the center, which make it a little bit safer, not touching the capsule in any circumstance. So we do the same on the other side, open up and then put the 2 blunt tips behind the iris through the pupillary aperture, and removal is done by the same forceps, pulling it, closing and pulling it out. So let's see some complicated cases, and this is a case of an hypermature cataract with fibrous tissue. We have some bleeding from the synecholysis, 2 19-gauge incision on the opposite side. The APX is inserted, open up, making sure that the tip is located behind the pupil, and just slowly release it and do the same on the other side. And then we can see that this patient is after irradiation from melanoma. It has a fibrous capsule that we need to cut with scissors. So we must have a very good and stable and large pupil. We cut the capsule with scissors, take it out with forceps to see there are very dense, hard nucleus that we can remove by direct visualization and implant a posterior chamber lens within the bag. And following the removal, the pupil again is going down a little bit and regains its normal configuration. This is a patient with an hypermature cataract with a Morganian cataract. She was blind for 15 years. We could not see anything into the eye. And after staining of the capsule and aspiration of this milky material, we can see this is actually a Morganian small cataract and a calcified capsule. We remove the nucleus and then put the lens in through this small pupil. Next case is a sclerofixation of a subluxated intraocular lens, and we do need to see where the needle goes in behind the optic and then goes out in front of the optic, and then eventually the pupil is perfectly centered. And the last case is a patient with pseudoexfoliation and severe phacodonesis. So we could manage to remove the lens material. However, the capsule was very phacodonetic, so we had to stabilize it using a capsule stabilizing device, and I prefer to use the capsular anchor. Now, this is done with a 9-0 ProLens. Today, we do it with a 6-0 ProLens with a flange technique, which we think it's much simpler, and then remove the 2 apex devices with the designated forceps. Very simple to remove, just close and pull it out. So our clinical experience includes cases with pseudoexfoliation, IFIS syndrome, uveitis, mature and hypermature cataract, closed angle closure with neophthalmos, coloboma, sclerofixation, iris fixation, persplantar vitrectomy, subluxated lenses, actually the entire variety of small pupil And we find that this device is very effectively dilates the pupil both in cases of routine and on complex cases of cataract. Thank you very much.
Thank you, Ehud. I think this is the time for a short discussion. We have a couple of minutes. So my first question to Suven, because we do have a range of devices. There are different ones. So your device is planar, and it is very good because it can be inserted through the small incisions, 1.0 in your case. However, at the same time, planar device it makes it a little bit more challenging to engage the iris. So tell us about your tips and tricks, how you do it more efficiently.
Yeah, thank you, Boris. Can I have my mic on, please?
Yes,
are you able to hear me?
Yes.
Can I have my mic on?
Yes.
Are you able to hear me?
Yes.
Yes. So, yes. So it's a very thin device. So and you're holding. Yeah. So it's a very thin device, and it's a very flexible, resiliently flexible device. So and you're holding it with the forceps. So you've got total control over it, and it doesn't hurt to bend the iris because it's fully reversible. And it really is a very intuitive device. It does not require any great learning curve. It's very simple. See a couple of videos and you can go ahead and do it. It's not very difficult to engage at all. And in fact, like you said, you probably talked in a lot of your presentations, and I've also done that. It's always a good idea to lift off the iris a little bit with a bit of viscoelastic under it so that it's easy to tuck in whatever, whether it's the scroll, your scroll, or eye-ring pocket or a B-HEX flange. It's much easier if you lift it off with a bit of viscoelastic.
We have some questions regarding if is it reusable, the B-HEX?
Well, it's officially sold as a single-use disposable device, and it costs a lot less than Boris's ring. So I guess you can use it, but then there are people who have reused it. But reuse, there is a problem with the device is that it spoils its mechanical properties. So I would caution you against reuse. It's sold as a single-use disposable device.
I would like to ask Dr. Luthra and Dr. Boris Malyugin. There are some physicians who have some difficult times to putting those rings when you have already done the capsulorhexis. It's much easier to put them on without performing the capsulorhexis. What are the tips that you use to put and position these rings after you started the surgery and capsulorhexis is always done?
Yes. Should I take it first, Boris? Okay.
Yes.
So personally, if I've made a rhexis and if I have a very shallow chamber, I will usually not use one of the rings. I'll prefer to go with the iris hooks. And then of course, you can put viscoelastic under the iris and typically go from the side, lift up the iris a little bit, and then engage the one of the iris hooks. And then it becomes much easier to put the other iris hooks because you can start from the area where you have the first hook in place. For ease of insertion, I really like Boris's ring, the Malyugin's ring. I enjoy the B-HEX as well because it comes out so nicely. It's nice and easy to put in there. But for I use both of them pretty often. So for very small pupils, I would probably go with the Malyugin's ring, and I enjoy how easily it can be inserted. Once I got the forceps which Suven makes, which he's recommended, it's become much easier to use the B-HEX as well. But if the pupil is really small and fibrotic, as he showed, you want to stretch it. Otherwise, the B-HEX may not, engage as well. But so that's one small limitation which I do find. But removing it is so much easier. But I think both rings have an amazing, they've really made life so easy. And for insertion of the ring, if I had to do it after the rhexis was made, I would probably put some viscoat, in the far end where under the iris a little bit, and make sure if the capsule is stained, it makes life so much easier, because I've had a complication once where we did manage to catch the rhexis in a very small pupil, and we were lucky to get away without having a broken one. But yes, I would caution people to be very careful if you have a rhexis in place to be sure that they didn't catch the capsulorhexis.
I agree with what being just said, and I think when you try to expand the pupil when you already done capsulorhexis, whether you use the ring or whether you use the hooks, there is a risk of catching the rhexis margin, and obviously you have to keep that in mind. And at least in my hands, I think it's a good idea to lift the iris a little bit. However, you have to be still vigilant about that possibility. So what I do, I insert the Malyugin ring, and then I try to move it left and right, up and down. And if I see that it's moving easy, that it's definitely not catching the axis. But if it is restricted in movement in some direction, for instance, vertical, then I understand that here is the area when I catch it. So as soon as you can recognize it, it's not a problem because you disengage the scroll and then engage it once again. And I do believe the same will be applied to more or less any other ring. Maybe Suven's ring having more planar structure, having a little bit less risky of in that case, rather than any other rings that are having such kind of a gap in between the two fixation elements. I must say like that.
If
you want to add something?
If I can add, this is exactly why I showed the second technique, going from the outside in, going from the surface of the iris. And this applies not only for the APX, it applies also for any kind of a ring. If you have a problem with the capsulorhexis already in the eye and the pupil is small, you can put the ring on the iris, ring, apex, or hooks, and then from the peripheral goes toward the center, so you would not catch the edges of the capsulorhexis, and you could do it step by step and very slowly. So in this case, you would not rupture the capsulorhexis.
Yeah. So
great tip. Yeah.
The difference I find within the B-HEX and the Malyugin, when you have a situation after the capsulorhexis, is in the Malyugin ring, we have to, when we're using it with the injector, the control is a little remote. So we are not actually able to hold the scrolls. It would be wonderful if you could hold the scrolls and kind of direct it right over there so that we are absolutely sure that we are not engaging the capsulorhexis. With the B-HEX, what happens is, since we are holding the flanges with the forceps, right at the flange. So the control is a lot more. And as you tuck the flange under the pupil margin and you advance it towards the periphery, the confirmation is immediate. Like if you have a resistance, you can see that the capsulorhexis has been engaged. So you withdraw and go to at a planar slightly higher. So that is an advantage with the B-HEX. And as you said, it's a planar device, so it goes in much easier. And you can see the notches which are flat and staring at you.
Yeah, and maybe I will add a few words that if you're a bit concerned that you will catch the capsulorhexis, I think it's a good idea, at least for the Malyugin, is to inject the ring, place it on top of the iris. Do not try to engage it at the same time, and then do it one by one with an instrument. And I think it's quite safe and easy to do that. My question goes to Ehud. So I've seen that you were working at 12 o'clock. So you're sitting at 12 o'clock. And of course, you have a good exposure of the iris on the exposure of the eye on the side. So any hints for the surgeon, and many surgeons are sitting temporal, at least in Europe and US. So any recommendations with your device, how you handle that when you're sitting in the other direction?
Yes, this is correct. My personal preference is to do it at 12 o'clock. I just like to do it instead of bouncing from one side to the other. But I did many cases in which I said temporal approach. In this case, in order to position the APX, I just ask the patient to look a little bit down. So let's make it easier to put one side, and then you ask him to look a little bit up, or move it with the forceps. But it's not a concern. I mean, it does need a little different manipulations, but it does go easily just as well.
Okay, because sometimes with the hooks, when the eyes, the eyelids are tight and the narrow, so we like to cut them to make them smaller. So which is obviously not possible with that device.
This is correct, but hooks are very long, much longer. So this is why they sometimes usually extend beyond the surgical field of the eyelids, but the APX is much smaller.
Okay, good, great point. Thank you.
It was a great session. I think we have the time, don't we, Ashwin?
We do have
Hello,
some
guys.
questions on the website. I'm not sure we will be able to answer all of them. Maybe,
Yeah, we might have to close this session as the other session is waiting.
Yes,
Right,
you
thank
need
you,
to.
everybody.
One minute, I need to move you on, but first, I like to say, Suven, Ehud, Boris, I'm a great fan of you because it's difficult to invent in ophthalmology. And Boris, I like to say, the iris expansion ring was divided before Malyugin ring and after Malyugin ring. Sorry, but me, Suven, Ehud came after. And Boris, thank you for congratulations for your ring. And I was inviting Nicole to this session because the rule about my boss is Ash. Ash told me only one talk for the speaker. Then let's go to invite Nicole because Nicole has a great experience in Canabrava ring. And Bruno, thank you. Bruno is now the president of the Brazilian Society. Gaurav, Luthra, thank you to be here too. And let's go to the next session. Thank you to be here today.
Thank you. Yeah.
And
Bye.
Bye. Let's go to the next session.
Thank you so much.
The session for today.